During an active ulcerative colitis flare, the mucosal lining of the gastrointestinal tract becomes deeply inflamed, raw, and ulcerated. The first-line clinical intervention for managing mild to moderate cases of this disease is 5-aminosalicylic acid, commonly known as mesalamine. Physicians also occasionally deploy it for specific cases of Crohn's disease when the inflammation is isolated to the colon. Chemically, 5-ASA is closely related to a household medication you already know, acetylsalicylic acid, or standard aspirin. Standard nonsteroidal anti-inflammatory drugs like aspirin operate systemically. You swallow them, they are absorbed deeply into your bloodstream, and they circulate to act throughout your entire body. This diagram illustrates the core pharmacokinetic difference. On the left, aspirin dissolves and circulates through the vascular network. On the right, 5-ASA takes an entirely different approach. It must be applied topically, resting directly on the mucosal lining of the gut to be effective. It does not need to enter the systemic bloodstream to reduce gut inflammation. This absolute reliance on direct physical contact with inflamed tissue dictates everything about how the drug is prescribed and engineered. Understanding this medication requires us to abandon the standard model of how pills work. We have to think purely in terms of targeted local delivery. In the treatment of inflammatory bowel disease, clinical success relies on the precise pharmaceutical engineering required to transport the delicate 5-ASA molecule safely past the harsh stomach acid and deploy it exactly where the anatomy is failing. To see why physical contact is required, we have to look down at the microscopic, cellular level of the intestinal lining. This visualization shows the primary biochemical drivers of gut inflammation. Here we see active cyclooxygenase, or COX, and lipooxygenase enzymes rapidly producing clusters of prostaglandins and leukotrienes. These are chemical messengers that signal and sustain tissue inflammation. When applied topically from the lumen side of the intestine, the 5-ASA molecule drops in and physically locks on to the COX enzymes. This binding causes an immediate halt in the local synthesis of prostaglandins. Simultaneously, 5-ASA binds to and inhibits the lipooxygenase enzymes. This shuts down leukotriene production, completely starving the inflammatory cascade at its source. The drug also serves a secondary functional role as a localized antioxidant within the gut environment. 5-ASA actively scavenges